We're just waiting for guys to join, then we start. When it's saying there's no sound.
Yeah, we waiting for people to join in basically.
Okay.
So, good evening, everyone. Thank you for joining our webinar for today. So we want to give people a bit of time to join. Then when we get a good number, we'll start. So just bear with us for a few minutes, please. Thank you.
Do you have a threshold of time?
You want to begin?
Dr. Kerry?
Yes, yeah. I'm still here. So let's give a bit of time for people to join in. So before we start, for those who have joined in, so thank you again for joining us today for our webinar. Today, the topic is pediatric sleep disordered breathing, and our speaker for today is Dr. Ankita Shah. We are also joined today by Dr. Elvis, who will be the MC for today. And we are also joined by Dr. June, who is somewhere. So she's also part of the team. So thank you again, everyone, for joining in. So KAPD, is an association for pediatric dentists and also general dentists who have a passion for treating children. Yeah, so it's open to specialist pediatric dentists, general dentists, students, and generally anyone else who wants to treat children when they are relaxed. So welcome again and thank you for joining us. So we'll start at 10 past. So just give us a bit of time more. Then once it's 10 past, we will start and Dr. Elvis will do the proper introduction for our speaker today. So wait a little bit longer. Thank you. Okay, it's 10 past 7 p.m. So Dr. Elvis, over to you. Thank you.
All right, thank you, Dr. Kerr, and thank you all for joining us for this webinar today. As Dr. Kerr has correctly put it, we have a presentation on pediatric sleep disorder breathing, tongue ties, and oral myofunctional therapy. So today we will not be covering our routine talks on cavities and other things that have been bread and butter, but we want to try and share a new paradigm towards the sleep disorder breathing, myofunctional therapy, tongue ties, and myofunctional therapy. We have our presenter for today, Dr. Ankita Shah, who's an MDS in Pediatric and Preventive Dentistry. She also has a fellowship in MFS Orthodontics from OWI Institute in Barcelona, Spain, specialized in myofunctional orthodontics, presented by the MRC, which are the guys in Myofunctional Research Corporation in Australia, who do the myo braces that we have previously been given talks on by Dr. Purvi Shah and Dr. Patel, I believe. She has also attended the Gold Learning Tongue Tie Symposium, also certified by Global Laser Oral Health LLC to perform laser frenectomies. I believe these are the tongue tie frenectomies that she will discuss with us today. She is the first Indian ambassador of the Breathe Institute to be trained by the world-renowned Dr. Soroush Zaghi, MD, nominated also for Specialist Dentist of the Year in 2019 at the Famdent Excellence in Dentistry Awards. So you can see we are in the good hands of Dr. Shah, who is going to carry us through this area that is minimally talked about, but of great benefit to our patients today. So over to you, Dr. Ankita, and let us all kindly give a warm welcome and listen to this good presentation by Dr. Ankita. Over to you, Dr. Ankita.
A very good evening to everyone. I'm going to start sharing my screen so we can start right there. Is that good?
Yeah, that looks okay.
I'm extremely excited to be introducing you all to sleep in pediatrics. It is my passion to make these kids sleep and breathe better and live healthier and a happier life. Here's a little about me. Yeah. So again, I would just mention I'm Dr. Ankita Shah, and I'm a pediatric and preventive dentist. And I'll just tell you a little bit about my journey, what led me to finding about sleep disordered breathing in children. When I first learned about crooked teeth, and I heard that there were some muscle dysfunctions which are causing crooked teeth, and that if muscle dysfunctions, we can align teeth. I was quite intrigued by it for the first time when I heard it. So I went on to learn, relearn. I unlearned a couple of things, and I realized that it is not just the muscle dysfunction, but it is also the sleep disordered breathing, mouth breathing, tongue ties, breastfeeding, and then interrelation of all these that is commonly affecting children. And we as pediatric dentists are going to play a really important role here. So when I actually went on to learn further about it at the Breathe Institute, Los Angeles, I realized that early intervention was the key. And we as pediatric dentists are going to be the first professionals to be approaching these children. Here's a little about my practice. So coming to sleep and breathing education, we must understand that there are multiple causes to sleep and breathing. So we must try and understand the causes from different viewpoints, different expertise, and different experience. Now, there was a little parable about the elephant and the blind man. Now, these blind men, what they did was they tried to feel different parts of the elephant, and they, in their knowledge, they limited experience, they started describing the elephant. So what I'm trying to say here is that similarly, sleep and breathing education also has been viewed by different professionals with some part or the other. But when we look at different perspectives to this common problem and have a multidisciplinary approach, we can really resolve this issue. So I would always say that while looking at sleep and breathing, we must have an open vision. We should be viewing it from every angle, and we will be able to achieve success in these cases. So what is oral and facial development? Is it genetics or is it environment? What is triggering oral and facial development? Can you all tell me a bit in the comments below? Yeah. Okay, so I guess most of you all are still mentioning as genetics, right? So let me burst this little bubble here. Genetics is actually the one that loads the gun, but environment is the one that is going to pull the trigger. So it's not new. It's been known since years, but we've not realized the importance of epigenetic factors. Try and recollect the Melvin Moss theory, the functional matrix theory. What was this hypothesis? He said that there are no genes for bone development. In fact, he said that the blueprint or the construction of this bone growth lies in the functional matrices. And these functional matrices compose of what? The lips, cheeks, the tongue, the mucosae, the connective tissue, the fascia, the nerve, adenoids, tonsils, airway, everything around it is actually the functional matrices. And any stimulation from these functional matrices is going to guide your bone growth. Now, Draper has also implicated this in 1982 that muscles are going to play a very important role in the development of facial growth and also leads to malocclusions. Now, this was a very interesting paper where what is soft tissue dysfunction? Let's first understand what is soft tissue dysfunction. It's an alteration in the muscular activity of the muscles. Now, Dr. Ramirez has stated that we as dentists should be aware about malocclusions which are caused by these soft tissue dysfunctions, and we should be able to identify what kind of malocclusions is this soft tissue dysfunction causing. So he stated that whenever we are creating a treatment plan to correct a malocclusion, we must include appliances which are going to eliminate the soft tissue dysfunction. He said that there should be a balance of forces from that caused by the cheeks and the lips and from that caused by the tongue. And at the same time, it should even align the teeth. So what do you think should be the best choice of appliances here? I think the functional orthopedic appliances are the best choices over here, where they're going to eliminate the soft tissue dysfunction also, and they're going to be giving us stable results, aligning the teeth, and also going to correct the malocclusion. Now, what are oral myofunctional disorders? Now, soft tissue dysfunctions are basically represented as oral myofunctional disorders. And these are represented as atypical chewing and swallowing patterns, picky eating, dental malocclusions, there could be mouth breathing, there could be certain speech problems, some non-nutritive sucking habits, thumb sucking, posture issues with a lot of forward neck postures and forward shoulders, clenching, TMJ disorders, and sleep disorders. So if we actually try and go back and try to understand the evolutionary process, our ancestors, if we see over here, had nice forward growing jaws and they had a very wide maxilla, right? But look at the modern man. We have a recessed maxilla, we have a downward and backward growing jaw, we have a very narrow jaw, and we have deeper palates. And what is all this doing? It's actually affecting our airways. It is making them smaller. Now there have been researches conducted which have shown that this recession in the maxilla is seen even at the age of 5 years. And why is this happening? Why are we seeing more crooked teeth now? Why are we seeing more wisdom teeth impactions now? Is that our jaws have become smaller and the teeth have become bigger? Yes, the jaws have become smaller. The teeth haven't become bigger. When we even look or compare the size of the muscles of mastication in the hunters and gatherers and modern industrial man, we can actually see how narrow these muscles have become. And why is this happening? There has been a change in the soft and mash diet consumption. We do not consume much of the roughage in the diet now. We are not chewing enough. So our muscles of mastication are not used enough. There is a change in farming methods. There's a lot of use of pesticides now. So whatever produce that we are eating, I would say you're having a lot of gut inflammation, gut imbalances because of that, which is also inducing a lot of mouth breathing. There has been an increased bottle feeding and pacifier use, which is damaging the shape of your jaws. And the minute your jaws get narrower, what we saw, that the airways are becoming narrow. Now, there is a very interesting finding about the screen time. If we notice that there was much less screen time in our previous generations than it is now. Nowadays, we often see kids sitting in front of the television or iPads or iPhones, and they've been viewing the cartoons and having their meals. And you'll most of the time see these kids sitting like this. Their lips are always open. So if their lips are open, they're going to be mouth breathing. They start habitually mouth breathing from there. Mouth breathing per se also has multiple reasons to it. There are oral restrictions, skeletal soft tissue dysfunctions, which we will talk in the slides now. So before I begin sleep disordered breathing, I want you to understand that there is a spectrum of pediatric sleep disordered breathing. And remember, I'm stressing on the word spectrum. Because of this, it usually starts with, I think the poll came in. Okay. So it usually starts with mouth breathing or noisy breathing. It moves towards UARS and then slowly towards obstructive sleep apnea. But mouth breathing and noisy breathing is usually the first sign that there is something wrong. So these kids may present to you with dry mouth. They may often have chapped lips. They may be feeling dry in their mouth when they wake up. They want to drink a lot of water. Also, these kids have a lot of dental cavities. They will have a lot of poor oral health. They may have a bad breath even after brushing. A lot of yellow teeth for them. You'll see these kids have frequent allergies. They will be falling sick quite often. They will have lots of tonsils, adenoids, recurrent cold and coughs. There could be lip ties, tongue ties. There could be tonsillar hypertrophies. Even the jaw growth may be affected. Then comes your upper airway resistance syndrome. Now, this is again something which is very common in children. Now, what is upper airway resistance syndrome? Unlike obstructive sleep apnea, there is not a complete stop in breathing. Okay. So when you actually move from your stages of sleep, you go through your light towards your deep stages of sleep. But while upper airway resistance syndrome, when you move towards the deep stages of sleep, because of some interference to the airway, you will not fall asleep into the deep stages. And this is going to trigger the fight and flight response. So every time you're trying to fall asleep into the deep stage, you will be having sleep arousals. And because of these sleep arousals, you will see these kids having a lot of hyperactivity. They will have attention issues. So they're commonly, regarded as ADHD kids, but not all kids are ADHD. Actually, a lot of times it is because of mouth breathing and UARS, they are behaving in this way. Their tonsils may be largish, but not so large. There could be a mildly high arch palate. There could also be some soft tissue dysfunctions with it. Now, obstructive sleep apnea is the stage when actually the mainstream medical profession will start treating it. Doctor, the poll is on. Do you want to shut it or do you want to continue it right now? So I'm very glad to know that most of them actually have answered environment now. But we're going to end this and yeah. Okay, so obstructive sleep apnea is the stage when actually the mainstream medical profession will start treating it. When there is a complete obstruction of breath, the child is not able to breathe a couple of times. It would be like 10, 12, 15 times every hour. And these children may have nightmares, they have a lot of bedwetting, they have anxiety issues, they have behavior issues, there's poor academic performances there. They also have delayed milestones. They're not much to their growth and development according to the other kids of their age. Their tonsils are also quite large. There could be restrictive frenulums. There could be high arch palates. There could be a defect in the orofacial growth. There could also be a soft tissue dysfunction. So what I'm trying to say here is that when we know that it's a spectrum and there is a progression of the disease, why can't we jump in early at mouth breathing and start treating these kids early? And remember that it's a syndrome. Okay, so not every child is going to present with 1, 2, 3. You cannot tick mark every symptom of it, but you need to start looking at the overall picture and then you'll be able to diagnose these cases. So this is an important slide which was adapted from Dr. Soroush Zaghi, under whom I've been mentored and proctored. Now, what he states that is mouth breathing often progresses to noisy breathing, which often progresses to snoring, and snoring often progresses to obstructive sleep apnea. But he makes a very important statement here that not all mouth breathing is going to cause obstructive sleep apnea. But obstructive sleep apnea always starts with snoring, and that always starts with noisy breathing, and that always starts with mouth breathing. So we need to start intervening early in order to prevent obstructive sleep apnea. So let's first have a look at the prevalence of sleep disordered breathing, especially in children. So what we saw in this study, this was a 6-year longitudinal study, and what they saw was that obstructive sleep apnea was barely 1 to 2%. But what was more common was snoring, what was more common was mouth breathing, and what was more common was upper airway resistance syndrome. So these are the sleep disorders which are actually having not a complete oxygen desaturation, but the symptoms of these were still dynamic, and they suggested that we need to have an early and continuous vigilance in childhood. So what causes this sleep disordered breathing? Is it only tonsils and adenoids? Remember that tonsils and adenoids are only tip of the iceberg, but there's something really deep in here that is actually causing the fire. Let's understand what are the various risk factors for sleep disordered breathing. You can call them phenotypes of sleep disordered breathing or various risk factors. It could be turbinates, adenoids, tonsils, septum defects. It could also be a high arch palate. Now I want you to imagine that's your nose and that's your palate. When the palate is nice and wide, we have a nice wide nasal cavity. But the minute the palate goes narrow, we have a narrow nasal cavity, which makes nasal breathing all the more difficult. Mouth breathing, retruded jaws because of mouth breathing or because of some other reasons. We also have a lot of forward neck and forward shoulders, which is also going to affect the curvature of the spine and is going to narrow your airway space. The tongue muscle tone as well as the posture of the tongue. Is it sitting high up on the palate or is it sitting low? So all these are different phenotypes or risk factors for sleep disordered breathing. We need to catch hold of what is causing it. But this was a very interesting study by Dr. Gimino and Huang, where they found that, in fact, pediatric sleep disordered breathing, especially in the non-obese kids, it was more often due to a defect in the orofacial growth. And this is where we as pediatric dentists are going to play a very important role. So let's understand what are the consequences of an untreated pediatric sleep disordered breathing. Now, there could be an effect on the child's social functioning or a social life, interaction with people, academic potential, as well as in the overall well-being. They generally have a moody child. There could be inattentiveness. There will be a lack of concentration and attention, poor cognitive development. These kids also have a tendency to bedwet. This is again because you do not enter the deep sleep, and this is activating your fight and flight response. So they lose control over the muscles and they start bedwetting. Similarly, when you also move into not moving into deep sleep, where actually the growth hormone is released, what happens? You're not developing at the same pace as the other kids. And remember, mouth breathing and UARS commonly affect this problem where you're not moving into deep sleep. Again, a childhood obesity has been a long-standing problem now. And again, not moving into deep sleep is going to have a difficulty in an increased resistance to insulin. And this is going to increase the childhood obesity. Now, these children also have a very high tendency to develop blood pressure, other cardiovascular diseases, diabetes, thyroid in their adulthood. So let's understand what's in this shape. How can malocclusion affect this entire spectrum? Now, when we look at malocclusion, it can affect your airway. We have already seen that. It can affect your eating, which is going to cause you a lot of reflux as well as digestion issues. It can affect your speech as well as aesthetics, which is going to affect the child's self-confidence. Now, when it is affecting the airway, we need to understand that how it's activating the spectrum of pediatric sleep disordered breathing. And when it is activating that, as we already saw, it is affecting your concentration and attention, which can result in hyperactivity and mimic as ADHD. We saw that it is affecting the release of the growth hormone. So it's going to affect your general growth as well as the facial growth. So if it is affecting that, it is definitely causing a lot of skeletal and soft tissue dysfunction, which is again resulting in malocclusion. And this malocclusion is again causing a vicious circle of problems. The spectrum of SDB is also causing frequent tonsils and adenoids. Now, there have been two schools of thought here. Earlier, everyone believed that because there are tonsils and adenoids, that's the reason you start mouth breathing. But there is also an opposite school of thought which states that when you're mouth breathing, you're actually exhaling out a lot of carbon dioxide. And when you're exhaling out carbon dioxide, you're sending a signal to your brain that you're breathing too much. If you're breathing too much, you need to slow down your breathing. So it's a body's compensation to narrow the airway by enlarging the tonsils and adenoids. The minute you start correcting the mouth breathing, the tonsils and adenoids frequently shrink in size. Again, a lot of immune factors are released in deep sleep, which is causing a lot of allergies. Clenching of teeth. This is a very surprising and interesting fact which we come across daily in practice. And we've always said that clenching will go away with some age and with time. It must just be happening like that. But in deep sleep, your body is attempting to open up the airway and your mandible comes forward, and being an unstable position, you start clenching your teeth. So it's often related to sleep disordered breathing. So let's look at this another interesting study. Now, this was again by Dr. Gimino and Huang. Now, what they did is they had a couple of infant monkeys. Now, they induced nasal resistance in these monkeys. They also went through a lot of orthodontic literature. They also studied a couple of children. Now, what they studied was these children who had obstructive sleep apnea. They did an adenoid tonsillectomy in them. But still, there was a relapse in the obstructive sleep apnea. And what they concluded was there was a very strong association between sleep disordered breathing and the growth of the nasomaxillary complex as well as the orofacial muscle tone. This is where we are going to play a very important role. What is other parts of research telling us? We've known about adenoid facies since 1868. And what are these adenoid facies? It's basically an alteration in your craniofacial growth, right? So as we've seen that craniofacial growth is going to predispose you to SDB. And we also know that whenever there is mouth breathing, there is going to be a change in your muscle tone. And this muscle tone is also going to worsen the craniofacial growth. So there was also a lot of study done with studying the EMG activity of the muscles. Now, what they did was, again, in monkeys, they induced nasal resistance and they studied the muscle activity of these monkeys. And what they realized was there was a very poor muscle tone and abnormal muscle tone whenever there was a nasal resistance. So it is very important for our children to learn to use these muscles correctly. So what they concluded in this research was that oral breathing is an important clinical marker, that there has to be some form of muscle dysfunction. They also said that it is also an important marker that there will be some obstruction to the nasopharyngeal airway, and there will be some disturbance to the interplay between the muscle tone, the breathing route, and the structural growth of the upper airway. So these basic functions like suction, mastication, swallowing, nasal breathing, all these functions, if there are some disturbance to their functioning, it is going to affect the growth of your craniofacial development. So we need these functions happening in an appropriate manner for having a correct craniofacial development. This is another interesting paper. Now, they found certain risk factors. What kind of risk factors in the craniofacial morphology are responsible for SDB? And they found that there could be a decrease in the maxillary and mandibular lengths. There could be a downward and backward placing jaw. There could be a forward neck posture. They saw an increase in the anterior facial height. There could also be a inferiorly positioned hyoid bone. And the posterior airway space is relatively smaller. This is one of the most recent papers where they found that there were 33.3% of children that were affected with SDB, and they were most commonly associated with malocclusions like overjet, anterior open bites, posterior cross bites. Now tell me, how often do we come across these malocclusions in our practices? Quite often, right? Yeah. So that's the reason I'm telling you that we need to start changing the way we look at these malocclusions and start evaluating for SDB also. So this was another interesting paper where they said that whenever we have a class 1 or a class 2 or a class 3 malocclusion, we are going to have a change in the pharyngeal volume. So we have a breathing or the airway right behind their jaws. So the minute there is a change in position of the jaw, the airway positions are going to alter. So what this paper is stating is that why can't we consider the entire somatognathic system as one unit rather than treating them individually? If we are looking at only airway, we are not going to look at the jaws. If we are looking at only the jaws, we are not looking at the airway. Rather, why can't we look at both the things together? So they also found that the craniofacial growth was highly influenced by the respiratory function. And whenever there was a change in breathing pattern, there was a lowering of the mandible as well as the tongue. And there was always an extended neck posture. Now I want you all to try one little thing. If you put your tongue high up on the palate like this and try and breathe through your mouth. Can you breathe through your mouth? It's impossible to breathe through your mouth when your tongue is high up on the palate. Now you position your tongue low. You will be able to nasal breathe, but you will often exhale out of the mouth. And this is how you start mouth breathing. You may start as partial mouth breathers, but slowly start converting into mouth breathers. Now, this was a very interesting book written by Sandra Can. Now, she's an orthodontist herself. And in this book, she states that when it came to her children having an orthodontic treatment, she didn't want traditional orthodontics for her children. She wanted an airway orthodontics for her children. She's also given a beautiful insight on how the environmental factors have actually affected our jaws as well as our airways. Now, when we look at this picture that is adapted from this book, we'll see that how there is a long face with a mouth breather. We have a forward neck, we have forward shoulders, we have a crooked nose, we have an open mouth, downward and backward growth, we have venous spooling, we have a recessed maxilla. So these are all signs of a mouth breather. Now, we as pediatric dentists are actually the first ones who come across these mouth breathing children. And Dr. Maria has given some nice clinical recognition guidelines where she says that there could be some kind of visual assessments. There could be some questions that you could ask these children's parents. You could also conduct some breathing tests. Now, these breathing tests are pretty simple. Now, it's something which we've learned in our undergraduate school also, where we actually see the fogging on the mirror, or we test water retention in the mouth. How long can the child hold water or air in the mouth? We test it mainly for 3 minutes. But mind you, this is not a test to tell us if the child is a mouth breather. It can only tell us whether the child is a habitual mouth breather or an obstructive mouth breather. And she makes a very important point here that to remove any kind of bias, we need to at least screen these children by 2 of these breathing tests. So, as we all know that 60% of your orofacial growth is actually completed by 5 years of age, and almost 90% is completed, 90 to 100% by 11 to 12 years of age. And your brain development, 90% of it is completed by 5 years of age. Now, as we saw the consequences of SDB and how it is affecting the brain development, do you think it is worth waiting? Isn't prevention the key here? What is actually the treatment line of a pediatric SDB? So, Dr. Guimino stated that the ultimate and the only valid finish line in pediatric SDB treatment is continuous nasal breathing, and not only during the day, but also during the sleep. So why they stated this was they came across a lot of children who were treated with adenotonsillectomy, and they found there was a temporary definite benefit for these children. But on the longer run, they had worse symptoms through their adolescence. And why was this happening? Because we only treated one part of SDB. What are the other risk factors? We never considered the other risk factors here. So this was another paper where they studied 24 children. Now, out of these 24 children, 11 of them underwent myofunctional therapy. 13 of them didn't undergo the therapy. Those who underwent the myofunctional therapy, as well as they did an adenotonsillectomy and orthodontics as well, these kids had an improvement in their AHI. But those kids who had only undergone the adenotonsillectomy and orthodontics, but no myofunctional therapy, they had a relapse in their AHI. So what they concluded here was that a combined orthodontic and myofunctional re-education was more successful than a single treatment alone. So every era is bringing about a change in the lines of thought and work. And it's indeed very gratifying for us as pediatric dentists to know that we as a profession can get along with the medical profession and we can resolve this arising epidemic of the pediatric sleep disordered breathing. So ADA in its policies has stated that we as dentists are often the first ones to identify the symptoms. We can discuss this with the other medical professionals and can work on these with a multidisciplinary approach. We should be able to identify the signs, symptoms, and the risk factors for SDB. We are the ones who are actually going to fabricate the oral appliances and change the craniofacial growth. Dentists should keep on updating their knowledge with respect to dental sleep medicine. Even FDI in its policies is recommending that dentists should understand the process of screening and treatment, and they should know how the other caregivers are also playing an important role here. We need to have a training for SDB patients. So what is oral myofunctional therapy? Now, any change in oral malfunction is going to have a lasting effect on your facial development. And the very need for orthodontics in every second or third child means that there is definitely some form of oral malfunction disorder. And this is often preventable. So, as the name suggests, it's a therapeutic approach towards the muscles of the mouth and the face such that they can perform their functions correctly as well as have the correct rest posture. So is this myofunctional therapy concept new? Not really. In 1918, Alfred Rogers had mentioned that there are facial exercises which are important for improving the functional activity. And he stressed that we should concentrate on the facial development rather than mechanical orthodontia alone. He also mentioned that it is very important to retrain the muscle if we are treating mouth breathing. Also, when we are aligning the jaws in a class 2 to class 3, malocclusions are being corrected. What about the muscles? No one has taken care of these muscles. We need to readapt these muscles to the new position. So in 1950, he again made a restatement of the myofunctional therapy concept to the American Society of Orthodontics in Chicago. And he stressed upon the value of myofunctional therapy in orthodontics. He said that it is not only advantageous for the orthodontist, but also there are huge benefits for a growing child here. So what are the goals of myofunctional therapy? It's pretty simple. The lips have to be together, you have to breathe through your nose, and the tongue has to be high up on the palate like this. It cannot be resting low. So we are now at a problem solving game. What is preventing the child from keeping their lips together? What is preventing them from breathing through the nose? What is preventing them to bring the tongue high up on the palate? An ideal tongue rest posture is very important to have the posterior aspect of the tongue resting high up on the palate. This will keep your airway open. But if your tongue is resting low like this, the posterior aspect of the tongue is going to cause the narrowness in this airway. And this will cause a difficulty or resistance to the airflow. And what is causing the tongue to remain low? It could be a tie, it could be tonsils and adenoids. Sometimes it could also be that a low tongue posture is causing tonsils and adenoids. And there are many other reasons for a low tongue posture. So when the tongue is sitting high up on the palate, you're going to get a nice wide U-shaped arch. And if you remember what I said in the beginning, we have a nice wide U-shaped arch. We have a nice wide nasal cavity. Now, you should remember that a tongue can exert 500 grams of force. Whereas what do we do with braces? We apply only 1.7 grams of force. So the tongue is your natural palatal expander. And when the tongue is resting low, we are going to have a narrow palate, narrows the nasal cavity. The minute you have a narrow palate, we've lost the length of the arch, the maxillary arch as well as the mandibular arch, and we are going to get crooked teeth. So now let's talk a little about tongue ties. Now it's been only 4 years where tongue tie was recognized as the phenotype for pediatric sleep apnea. Now in this important paper where they recognized this as a phenotype, they did a retrospective analysis of 150 children. Now all these children had obstructive sleep apnea. They divided them into two groups. Now there was one group which had large tonsils and adenoids, and they had an obstructive sleep apnea, but they did not have any frenulum issues. There was another group which had no tonsils and adenoids. They had obstructive sleep apnea, but they had a shut frenulum. They had used the Murchison's protocol over here. Now, what they concluded here was that whenever these children had a short frenulum, they tend to show the signs of obstructive sleep apnea much later in their lives. And they are actually more severe because they bring about a lot of change in the craniofacial growth. So I want you to remember here is that there are different phenotypes of sleep apnea, and not each child with sleep apnea is going to present to you in a similar form. For example, I can say that there could be some children who have tonsils and adenoids. They have a pretty good malampati. They do not have much of a high arch palate, but their AHI is very high, say 11. Whereas there could be another child who could have a short lingual frenulum. The malampati is also poor. They have a very high arch palate. They have crooked teeth. And believe me, these kids will have a much higher AHI than the previous example also. So what they came across through their research was that these kids, whoever had a will show sleep apnea much later in their lives, but they may show dysfunctions in breastfeeding. They may have picky eating. They may have a lot of change in their orofacial growth also. So there are some tongue ties which are obvious, and there are some which are not so obvious. So the tip of the tongue raising up is important, okay? But what about the back of the tongue? These kids may do okay with speech and swallowing also. But what about the compensations it's creating on the floor of the mouth, your neck muscles, your shoulder muscles, and other compensations which may show a lot of damage later on in their life? So I want you to understand that tongue tie is one part of the puzzle of pediatric STD. I want you to take a step back and remember that not a tongue tie release can cure SDB in all children. So it is definitely one part of the puzzle, but not the only part of the puzzle. So I don't want you to go back understanding that, oh, this is a tongue tie, let's release it. No, that's not where we are and not what we are looking at. In earlier times, most commonly the measurement that was used was the Kotlow measurement, where they actually measured the frenulum length. But what about the functionality of the tongue, right? What about the back of the tongue going up? So what I'm trying to explain here is that it's not only about the length of that frenulum, but about the function and the tongue mobility, because the tongue has to form a wave and swallow. So the latest measurements that have been used is the TRMR scale, where they are measuring the ratio of the complete mouth opening to the ratio of mouth opening when the tongue is on the spot and the mouth opening when tongue is suctioned up on the palate. So this was the TRMR scale, and they stated that whenever it was less than 25 to 30%, it means that there is a tongue tie. But I also want you to understand that a lot of times the functioning can be affected due to other reasons as well. Like there could be muscle dysfunction, there could be tongue space issues, there could be a low toe tongue. So we have to evaluate everything. So what I want you to understand here is that the paucity of our knowledge right now in orthodontics etiology is pretty poor, and it has compelled us to attach the cause-effect relationship from the wrong end. But let's start working backwards and we will arrive at the beginning. How nice it would be if we can view it from the other angle. So what I'm trying to say here is that we've often come across procline incisors, and we often say that it has been caused by a lot of habits, and we say that the habits are the primary causative agents. But are they truly the primary causative agent, or is it merely a symbiotic related factor? Let's see a couple of examples here. Now, when we have a normal swallow, the tongue is resting nice and high up on the palate. The muscles are at rest around the face, and you're going to continue your swallowing. Whereas when you're tongue thrusting, the tongue is going to come low, lie in between your teeth, strain all the orofacial muscles. So is tongue thrusting the primary etiologic agent? I want you to look at this image again and start seeing what else can we see over here. Yes, you're right. We can see the tonsils, and these tonsils are causing the tongue to remain low. And this low tongue posture is then causing the tongue thrusting. So can we say now that the tongue thrusting is just a merely symbiotic factor and not the primary causative agent? Let's look at another example. Now, we've already said that mouth breathing is a merely symbiotic related factor. Now, in 1939 also, Dr. Weston Price had stated that mouth breathing, diet, malocclusions, these all were interrelated. And we see that now in these images. See the modern diet now today. What has happened to our facies? We have long facies, we have narrow nasal nares, we have a downward and backward growing jaw. All and everything has affected our airways. So the diet is actually the primary causative agent, and we've always misregarded what's the primary causative agent. Let's have a look at this little video.
What am I doing? Which way should I go?
That depends on what you see.
Ah, how convenient. Enter omniscient monkey right on cue.
Well, you know what they say. When the student is ready, the teacher appears.
That's it. No more fortune cookies for you. Hey, where'd you come from?
Oh, the better question is, where are you going?
Oh, someplace wonderful, mister. Where you didn't happen to catch the song I sang a few minutes ago, did you?
I didn't have the pleasure.
To recap, I want to live in some beautiful place outside, a carefree place where I don't have to hide or worry.
A life without worry. You seek Hakuna Matata.
Harpuna Tomata?
Hakuna Matata! It means no worries.
Perfect. Mind taking that stick of yours and drawing me a map up? Oh, hey!
To find it, you must look beyond what you see.
What the heck is that supposed to mean?
It means look beyond what you see.
Beyond what I see. Get a load of the monkey getting all existential on me. Beyond what I...
So this is a very lovely snippet from Time. I hope everyone has seen this. That this is very much want what we have actually. There was this other interesting paper where they found that mouth breathing not only during daytime but also during sleep. Now they studied some 35 children. They had tonsillectomy done, and they also had OSC. They had been treated with orthodontics. Couple of them perform myofunctional therapy, couple of them did not perform myofunctional therapy. And even when they did not perform, they were fairly decent through their daytime during sleep. So we also need to start assessing mouth breathing and sleeping, and not only through the daytime. So there was this another paper where they found that nasal disuse, that's your mouth breathing, and tongue motor immaturity, which is actually your low tongue muscle tone, were associated with high respiratory event index. And they found that the craniofacial dysfunction from having a pronounced impact at a younger age. So that's when we as pediatric dentists are going to really play an important role. And that's why we say that airway or myofunctional orthodontics should be a new normal. What is airway orthodontics? Now, traditionally, orthodontics has had an focus to align the teeth. But airway orthodontics has more of a function focus. So we are going to be treating the causes. We are going to have better airway, more stability. It's going to improve function. And as a byproduct, we are going to get straight teeth. Let's have a look at this video.
Problems. I had no functional issues previous to orthodontics. Okay, so maybe there were some like breathing issues, or maybe I never used to snore. That was another thing. I don't snore still till date, right? But there was no functional issues as such. Like now I feel with my joints clicking and popping sometimes, right? So post orthodontics, my teeth came into position, right? Like you can see, my bite is compensated for, right? But what happened in bargain was like my chin was pushed back and down, right? So if I leave my lips at rest, it shows a lot of my lower incisors, right? And that it has increased my interlabial gap significantly. I've never had any issue with closing my lips pre-orthodontics. Even with my teeth protrusion, I used to do fine because there wasn't this, like my lower lip didn't used to hang pre-orthodontics. Like post-orthodontics, this has been an issue. So I've been struggling. That's why my lower lip has become a lot thicker, right? Because I continuously try to purse my lips close. So in that scenario where I try to close my lips forcefully, because orthodontics has pushed my face down and back a bit, right? I'm not saying it was perfect before this, but it has done that to some extent, and I can notice that. So what I try to do is I try to close using my lips, and I recruit a lot of other facial muscles. And previous to this, I had no such asymmetry in my face, which is now, which I can now notice. It's quite minor, but I can notice it in the photos. Like you have to be looking for it, and even then I can see like my jaw is getting canted a bit on this right side, where I'm putting much more pressure to close my lips and obtain a natural lip seal, right? So I can feel like the right joint is suffering a bit. So this has been caused because maybe like the interlabial gap has been increased a lot. So that's an issue I feel that orthodontics doesn't address, right?
Could you even tell me about what you felt as a child, like about the habits, and what you said that you could relate to some signs like moodiness and all of those things as well?
Yeah, like basically for all my school life, like even if when I came to learn about orthotropics, myofunctional therapy, and all these things, like I started noticing my childhood pictures, right? Even from the start, when I was born, from the get-go, I had like always an open mouth posture. Like you could be right saying like I was mouth breathing, but I never felt like I had like we take these things for granted, because bedwetting as a child is taken for granted. Like that's what children do, right? You just have to be trained. That's what people thought. But I could feel a lot of things, like academically. When I was in school, I used to feel completely lost. Like I wasn't there. When I was there, I was mentally there, right? And when back in my house, I was completely hyperactive. Like I was a ruckus. Right. Even so, like late into my teens, my mother had to get me some sort of medications that would slow down my metabolism, or like make me a little less active, right? So that was the thing. Like when I was, and even into my preteens, like that was the main part. Into my preteens, that was when I started noticing like I had trouble breathing. There were moments when I was sleeping alone and I would feel like I can't breathe, I can't get a full breath in, right? So maybe down the line I started compensating it by mouth breathing and leaving my mouth open. And I didn't know like I thought that was a normal thing, right? Because you never notice these kind of thing unless you are aware about the issues. Like mouth breathing is wrong. We're not told about this when we are children, right? Nobody tells us about this, not even your parents. Like it's not like they don't care, they just don't know. Like these are issues. So that's what I felt. And these
So
were
how
those
long
issues,
were you
like,
thumb sucking then?
Thumb sucking till I said pretty long, right? And like into a 9th or 10th standard, maybe 9th standard, yeah, 9th, 7th, 8th, 9th standard. So pretty late into my teens. I used to have.
So, did we see how traditional orthodontics has actually damaged things for this child? There has been TMJ issues right at the age of 30 years. It's really sad to see that such young people are having issues because of an incorrect orthodontia. This child who was bedwetting in childhood, you think a 14-year-old child would be sucking his thumb only for psychological reasons? It's impossible. There has to be something beyond it, right? Couple of things that the child mentioned, that he was always moody, he was very inattentive in class, he felt depressed. So these are all signs of an SDB. And what traditional orthodontics is doing is they are masking the skeletal malocclusion by correcting the dental alignment. But masking the malocclusion isn't improving our airways. In fact, they are retruding your jaws. And most of the time, these kids are supposed to bite like this. And that is causing a lot of pressure on your TMJ joint because of the retroclination of the incisors that they put in. So in orthodontics, we generally move teeth, whereas every orthodontics, we are going to cause a lot of change in facial function, facial growth. Now, orthodontics only starts after all the teeth have erupted, whereas AV orthodontics actually focuses treatment from 3 to 4 years of age. In orthodontics, we focus on pushing the teeth back. In AV orthodontics, we want to focus on bringing the jaws forward. It has to be nice and wide as well. Orthodontics most commonly addresses with extractions. AV orthodontics will avoid extractions. They will want to make space for the teeth. There's a high tendency for relapse in orthodontics, and that's the reason for lifelong retainers over there. Whereas with AV orthodontics, there are no use of retainers. As we already saw how orthodontics has ignored the airway space, AV orthodontics focuses on the airway space, and how it has also damaged the TMJ. Whereas airway orthodontics, because we are correcting the skeletal malocclusion, it is going to improve your TMJ stability and function. Now, this was an important case report. I would say there are many such case reports now where there have been children with sleep disordered breathing, they were clenching, grinding, and other signs of SDB were present. They had an high AHI also. So they were corrected with certain prefabricated myofunctional appliances. They used some myofunctional therapy with it, and their AHI improved and was well maintained even at 6 months post-therapy and post-treatment. So definitely prefabricated myofunctional appliances will work for SDB, but I also want you to understand that there are certain limitations of these appliances, and we should be we should understand what are the limitations and where we can use other appliances, how we can work on airway orthodontics together with a lot of thought processes. So as in orthodontia, we have always been asked to wait and wait until all the teeth have erupted. But Dr. Bowman makes a very important statement here, that it's actually a very brave or an ignorant man who is taking the responsibility to advising delay in a progressing malocclusion. If we can see that there is a malocclusion, why can't we guide it before? we as pediatric dentists hold up the responsibility of guiding that developing malocclusion into a into no malocclusions. So what I'm saying here is that the current treatment in medicine is to treat only when the patient is on fire, when the tonsils and adenoids are so big and blocking your airway, when this growth and brain development is completely over, when these children are facing sleep apnea and they are extremely anxious, hyperactive, they're feeling depressed, they're falling asleep. Wouldn't it be better if we could intervene when there is smoke? So what I'm saying here is that we cannot expect one person to know every aspect of pediatric sleep disordered breathing. But we as pediatric dentists also play a very prime role into this. And along with a multidisciplinary and an interdisciplinary approach with other medical professionals, we can help resolve this epidemic of pediatric sleep disordered breathing. Dr. Guilleminault, who is actually the father of sleep medicine and the founder of this journal Sleep, has been working since years on finding the early risk factors for pediatric sleep disordered breathing. And what he says that this is an arising epidemic in children, and in fact there are more number of cases of SDB than coronavirus right now in the world, and it will need a multidisciplinary and interdisciplinary approach. So my team takes a very multidisciplinary and interdisciplinary approach where we actually focus on a lot of structural issues like tongue ties, tonsils, adenoids, nasal obstructions, correcting the orofacial growth. We also look at the functional assessments and we perform myofunctional therapies for children. We also look at a lot of behavioral assessments where we look at their sleep hygiene patterns. That is, if they are falling asleep according to their body clock or no, or are they misusing their body clock. We also look at a lot of dietary interventions also over here. Now, let's see some cases over here. Now, this was this child who had mouth breathing, and we perform myofunctional therapy. We use a prefabricated myofunctional appliance here. And look at what this parent has to tell us, that the cold and cough allergies completely disappeared. This child used to get very irritated, had difficulty in organizing tasks. That was completely improved. Her oral hygiene improved, halitosis improved. So overall, all the aspects of SDB had improved for this child. This was a very interesting case where this child was having a class 3 malocclusion. He had early signs of ADHD. He used to have a lot of change in sleep positions, bedwetting till 5 years. He had a tongue tie also. Now this child has been used with a combination of multiple things. We have changed the facial growth. We've used prefabricated appliances. We've also used expanders. We've also used myofunctional therapy, and we've also performed a tongue release for this child. And that's how we could correct the postures as well. Look at this forward neck posture. Look at that straight posture now. This was another very interesting case report where this child had reported to us again at 9 years with a class 3 malocclusion. She had a deviated nasal septum, noisy breathing, frequent changes in the sleep position, completely recessed maxilla. Look at how myofunctional therapy and use of prefabricated appliances has grown her maxilla forward. If you can notice the bulge and the depression here. Look at how this is corrected beautifully. Obviously, it needs more intervention with some amount of expansion and alignments, but look at the beauty of epigenetic factors over here. The minute we start correcting the causative factors, how beautifully the jaws have grown forward. This was another very interesting case where this child at 10 years of age, he had, the parent reported that there were many times they felt that the child stopped breathing in the night. He had enlarged adenoids, crooked teeth, a tongue tie as we see, and snoring as well. Now, again, we've used a multiple approach towards this child. We've corrected the tongue tie as well. we are working on his alignments as well. We've given him breath retraining. We've performed myofunctional therapy for this child. And I would like you to hear how beautifully we've achieved a fascial release. And this is called as functional frenuloplasty, where the tongue is moving up independent of the floor of the mouth. Let's look at what the child has to say here.
Hello, I am Harsh. I was operated by Dr. Ankita for tongue tie. Before that, I couldn't lift my tongue too high and not move it across the whole mouth. But after I was operated, my tongue felt a bit free and swallowing was easy. It felt like a whole stone was rolled out of there. Thank you.
Look at how he felt easier to swallow. I, in fact, remember him immediately during the process. He said, I'm feeling something free in my body. Okay, this is how beautifully the fascial system, when we do a good functional frenuloplasty, this is what a tongue tie release should be. Look at what the tongue tie release and correct position.
Once the tongue tie was released, in few days time we observed that the pattern of the sleeping posture of hers was changed. He was quite peaceful in sleep. His mouth was shut. He was taking breath from the nose. Snoring was absolutely stopped. So overall, we felt that he is very comfortable in sleep, and I must give credit to Dr. Ankita for that.
So basically, what he said that immediately after the tongue, when it started reaching high up on the palate, the snoring was completely gone. So imagine how the posterior part of the tongue would be blocking that airway. So what I'm saying here is your face is often the window to your soul, but it is also the window to the oral health status of that person. So should we just do nothing? It is impossible. Or should we just do it? Everything is possible. And it's indeed time for pediatric dentists to start developing a new thought process, think out of the box, and start resolving this arising epidemic of sleep disordered breathing. And I would also like you to introduce you all to our pediatric airway and breathing course. And we will be having one of these programs in the month of February. So as we all know that this is a very intense subject and there are multiple aspects that you need to know in detail. So we are going to be holding this course over 5 days where we are going to discuss in details about the sleep disordered breathing, tongue ties, the application of myofunctional therapy, application of airway orthodontics. We are also going to be discussing a lot of practice management and also having a lot of case discussions here. Feel free to contact us. And I really thank you all for listening to me. Doctor, I'm open towards all the questions they have.
Right. Thank you very much, Dr. Ankita. That was a very enlightening presentation. And this, for once, has not been about drilling and filling or pulling out teeth for straight braces. And now we have a lot more knowledge concerning that. Maybe just a small question from, a rather short question from my part. Would you say that a lisp in kids has anything to do with indication of sleep disordered breathing?
Well, a lisp could have multiple reasons though. Sometimes there can be, sometimes it can be because of the tongue tie. Sometimes it can also be because of the low tongue tone. Sometimes it is also because of the reduced tongue space, that is your narrow jaws, and your tongue is not reaching high up on the palate, and still you're getting a lisp because the tongue needs to move to certain positions of the palate to give out certain syllables.
Mm-hmm.
Type M, B, M, these syllables have a difficulty when the lip tie is there and you're not able to close your lip.
I see. Okay. Thank you for that. And maybe the last question. Does checking for oxygen concentration in our patients at before we see them have any contribution towards diagnosis of sleep disordered breathing?
So in earlier times, they used to use the PSG. They used the as the in-lab one. Then they started using a, but you need to understand that they're putting so many wires around that child, and this child is automatically going to have a disturbed sleep. So we are not going to be recognized. So in the newer standards of examination, they say that we do video monitoring of these kids, and you can actually observe the movement of the chest. You can observe whether there is a noisy breathing, how they are arousing from shallow sleep to deep sleep. So in my, whenever I evaluate these kids, I always ask the parent to have a couple of videos at least 4 to 5 hours after they are dead. So I can get a picture of the deep sleep of how this child is sleeping, what are the compensated patterns the child is showing me. Especially in India, we are not too towards PhD. Parents are a little very anxious about it. So here it is not followed much, but in the Western countries, they still perform a PSG, especially in cases of when they feel that there would be an OSA. But most commonly in children, you will find mouth breathing and UARS. UARS is very common in children.
Okay. All right. So thank you, Dr. Ankita. We have seen good testimonials from your patients there as well. And now I will open the questions to the floor. We have 4 questions here. We'll start with the first one from Dr. Pauline Karanja. Please explain again how clenching is associated with sleep disordered breathing.
So, hi, Dr. Oleen. Thank you for your question. Now, when you are sleeping, you go through certain phases of sleep. Okay. Now, there are 5 phases, which the first are your lighter stages, 3 and 4 are your deep stages, and the 5th one is your REM sleep. Now, you fall asleep from each stage, you progressively fall into the deeper stages of sleep. And when you're falling into the deeper stages of sleep, the muscles are going to relax. And tongue is also a muscle, so that's also going to relax, and it falls back into the airway. Now, when this tongue falls back into the air, blocking the airway, you're going to struggle for breathing. Okay, so now in this struggle for breathing, there is a fight and flight response. That's your parasympathetic drive will get activated. And in this fight of breathing, you will tend to bring your jaw forward like this. You tend to bring your jaw forward. It's an unstable position. So you're going to start clenching your teeth as in compensation to open up the airway. That's what. Yeah, doctor, I think that would help.
Okay. All right. Thank you very much. I hope, Dr. Pauline, your question has been answered. There's another question from anonymous attendee who says, when should we refer a case to an ENT?
So again, you need to first have a understanding of factors. If you definitely, if you see like a size 4 of the tonsils, or you're saying even a size grade 4 of the adenoid, blocking the airway, then there is no question. We should refer it to the ENT, perform the procedure, but at the same time, you need to make sure that you perform myofunctional therapy, restore nasal breathing. Otherwise, there will be relapse of these adenoids and tonsils. So most of the things you will, as a pediatric dentist, if there is an incorrect jaw, you will need to correct your jaw alignments. You will need to widen those jaws as well. So that's how it is. Like there will be an ENT referral, but you will have to evaluate when do you want to send it to ENT.
Okay. And our next question is from Dr. Shah. How do you treat a 3-year-old child with myofunctional orthodontics? How would you get a 3-year-old child to cooperate?
Right. So See, I'll be very practical at this juncture. A 3-year-old child, in my opinion, would show you a lot of signs of SDB. Okay. If there are simpler procedures where there is muscle dysfunction, I would work with this child with a myomunchie, let them bite on it, because it's very difficult today as a 3-year-old child, get cooperation out of that child to perform these actions. So myomunchie is more like biting on it and chewing on it. So it's a little more easier for that child to adapt to it. And later on, as the child grows and becomes, I will perform an appropriate myofunctional therapy for this child. Now coming to a tongue tie, now in the West, they again have a lot of CO2 lasers over there, and parents are pretty much okay with general anesthesia as well. So you can perform, evaluate what are the risk factors and then perform the accordingly the procedures. Uh, so, but in my opinion, in India, we are not too comfortable with general anesthesia. They avoid it a little bit. So I wouldn't try and perform the tongue release procedure without a CO2 laser on a dental chair. In India, we are still stuck with diode lasers. We are not using CO2 lasers here. So if we'll do more harm than benefit. We are not going to be correcting it completely. I would evaluate my pros and cons and decide when do I start with. But a myomunchie is a great start for at least developing the muscles of mastication, achieving a correct swallow. This will help you at that juncture.
Okay. Thank you, Doctor. The next question we have is from Harbaksh Jandu. Can I, as an ENT surgeon, do that course? Glad to have an ENT on board.
Yes, you can do it. It will be my pleasure. I would learn much from you also.
All right, Doctor, you're more than welcome to do the ENT. Again, from Dr. Pauline Karanja, do you get referrals from ENT specialists for children who have undergone adenoidectomy and tonsillectomy?
Yes, so that's what we work here. So I work here as a multidisciplinary team where we are actually training doctors, where we spread across the knowledge, and this is how we are going to grow this field. That's when even the ENT doctors will, a lot of ENT doctors are doing the surgeries, but they do not focus on rest breathing. So today, if we as pediatric dentists know that we can change this fact, we need to start approaching the medical field professionals. So in fact, we have an Airway collab that's been initiated by the American Academy as well as the Breathe Institute, where they are across a competition among different field of doctors. And, where they're going to be sharing a lot of presentations. We are going to have individual case discussions, reviewing a lot of articles, how we can spread across the knowledge amongst the other professions and work as a team today.
As you said earlier, it's a team approach, so let us all get them educated as well. Maybe just as an add, there's a book written by George Meredith, maybe you've read it, and that book is, George Meredith is actually an ENT surgeon, so he will actually explain better to the ENTs what it is that the contribution of the dental part of things, where we're doing the palatal expanders and other myofunctional therapy, will benefit their patients in ENT as well. So maybe you can share that book with your local ENT people. The next question from anonymous attendee. For the Kenyan practitioners, any studies that have been done locally on the topic? Anyone that has worked in conjunction with an ENT to follow up, offer multidisciplinary treatment on patients with sleep disordered breathing? If not, what advice would Dr. Ankita have to someone looking to conduct a study on the same here?
There have been a lot of studies which have been conducted internationally, and there is a lot of research still being done, and a lot of research every year. There is n number of research into this field. If we actually start looking into it, so with regards to ENT and adenoid tonsils, there has been enough research available to tell us that why myofunctional therapy is necessary with it, or why an orofacial correction is necessary. It doesn't need further research in that area as such. We are going to have a repetition of an answer maybe.
Okay. All right. From Dr. Nisha Sapra. Hi, Dr. Ankita. Please explain the part where mouth breathing, you exhale CO2 and the brain thinks that you're breathing too hard.
So we need to understand when we've always learned that oxygen is important. Oxygen is important. But what about that carbon dioxide? Now this carbon edge of your blood, and this is what is going to actually cause your RBC and release the oxygen from there. So if there is not enough carbon dioxide in your body, you will not have enough oxygen also in your body. And in mouth breathing, when you're exhaling out a lot of carbon dioxide, what is the signal which is going to go to your body? Breathing too much. And when you're breathing too much, you will try to reduce your breathing. Now, to reduce your breathing, your body is going to compensate. Now, how will your body compensate? That I want to narrow down my airway so that you can stop or reduce the breathing. Now, for that narrowing down of the airway, automatically the body has enlargement of the tonsils and adenoids. It's really been miraculous when we've also seen that the minute we correct mouth breathing, these tonsils and adenoids regress in size and they no longer require any surgical removal. So that's how the interplay, and there have been many schools of thought into it, and this is something which Buteyko has mentioned. This is how they have been.
Okay, I hope that's clear for you, Dr. Nisha. Then there's a doctor asking, do you have online courses on airway orthodontics?
Yeah, so we were willing to start this program online in the month of December. We'll have a look at how the situation is with the pandemic, and then accordingly help you all with it. Because I believe one-on-one we will learn a lot more, and then let's see how time goes, and then we will see how to go about it.
Okay. So there's a course coming up as we progress. Dr. Harbaksh Jandu, I think this is the ENT doctor, has two questions. Thank you. How do you apply for the course that I think the 5-day course that you mentioned earlier? And apart from the online bit of the course, will we have to attend some practical aspect? If so, where?
The courses, you can contact me on courses@dentician.in. I had shared across, I'll leave across in the messages here in the also.
Yeah, maybe leave a link there for us. All right, thank you. That's, I think our ENT doctor can get more information once he gets in touch. And then I think this is another question from Robert Muriuki. He says, is it beneficial to perform a tongue tie release in infants less than 3 months old?
Doctor, thank you for your question. Again, this is an extremely vast topic, and we've been training a lot of lactation consultants also into it. We've done tongue releases even for a child like 10 days and a younger than that also. If required, yes, you have to do it. That doesn't mean, again, I'm going to repeat myself, do not go and cut everyone's tongue. That is not what I am saying. We need to understand the implications, and then only we go ahead with the procedure. I hope, doctor, that helps. Any further questions into it?
All right, thank you, doctor. And thank you, doctors, for attending. This was a very informative session whereby we've learned about airway orthodontics and what it entails and what the environment does to and not genetics does to our malocclusions out here. So I think that is what they call epigenetics in your field of study. And thank you again for the wonderful topics. The courses that Dr. Ankita has mentioned, as you've seen in the chat box, you can get the email where you can reach the same team that will provide for the course and then maybe get more information out of it. Thank you so much, Dr. Ankita, and thank you for that informative course. Knowledge about the Airway orthodontics. Let us all practice to not always pull out teeth, but let us work on improving the airway of our patients to reduce the retainers. I think there's one person raising their hand before we call it a day. Oh, okay. There's no question. So I'll pass this back to Dr. Kere and maybe the KAPD officials for the final statements, and then we can call it a night for us here in Kenya.
Okay, thank you so much, Elvis and Ankita. I have learned quite a lot today, and I'll definitely be consulting Dr. Ankita to help me with some of the difficult cases I encounter. So and again is to thank everyone who attended today, and also to thank a lot Dr. Ankita, because I'm sure it's almost 11 p.m. where she is. So thank you for staying up. I hope we didn't take too much of your time. I know we did, but thank you for allowing us to steal some of your time. So thank you, everyone, Elvis and everyone else. Thank you and good night, and have a safe evening, everyone. Bye.
Bye.